start recording. So, well, welcome to everyone. Today's the last of our DCAP seminars for this semester. And I thought I would offer to do this presentation on tics and Tourette's. And the main reason I thought I would talk about tics and Tourette's is because actually the 7th of June is World Tourette's Awareness Day. And often in the end of May and first weeks of June, the Tourette's community do a range of training activities and awareness raising activities. And so I thought, well, that's then perfectly suitable for us to do a talk and just a reminder and an update on tics and Tourette's. I wonder how many of you, just show me hands, how many of you have worked with people with tics and Tourette's? And somebody isn't muted. So just show me your hands. How many of you have worked with people with tics or Tourette's? I get thumbs ups, very good. Excellent, okay, so many of you. But I thought what might be, what I thought I wanted to do today is start with a short movie, just to show everyone a little bit of something about Tourette's. And I'll tell you in a second why I thought it'd be good for us to start with a little movie. And then I'm going to focus on background, classification, phenomenology, some of the comorbidities, co-occurring conditions, and treatment principles. We can't talk about details of treatment on a seminar like this, but we can talk about the principles of treatment. I put pathophysiology, etiology in brackets at the bottom because A, there's not really time to talk about it. And as you will see in the one slide I'm going to show, we don't actually really know what the actual pathophysiology and etiology of Tourette's are. And so that's why I'm not going to try and take a long time to talk about the etiology or pathophysiology today. I wanted to start, and I hope my technology will not fail me today, with a short video on Tourette's. And I think this is there are lots of things that you can see online about Tourette's, but this is a particularly nice one done through the American Tourette Association. And it's actually a short movie, and you can, if we can't watch the whole thing today, you can go and watch it afterwards. Produced by a young woman who has Tourette's herself. And I think it's a beautiful example of just not showing the phenomena of Tourette's, but showing real people and what it feels like to live with tics and with Tourette's. Because in our business, we're not just interested in the phenomenology and in the characteristics and in the classification. We're interested in thinking about the overall needs of people who live with tics and Tourette's. And that's my main message really for us today. And therefore to understand their experience of their tics and Tourette's. So let's see, I'm going to try and show you a few minutes and then we'll come back to the presentation. Fingers crossed for the technology.
What tics do you have? What tics did you have? Did I have in all my years of having Tourette's? Or do now? Okay. What kind of tics do you have? My worst one right now is I go like that a lot. Yeah, I blink a lot too. And I roll my eyes back. I hum.
That's a new tic.
I move my nose and mouth. And I go like this with my hands when I'm nervous. Yeah. I shake.
I'm moving my eyes up, it gives me a headache. Also shaking my head, doing this, that's 3. Bending down, 4. Making vocal tics like, ooh, and ooh, that's 6.
Gonna get the nipple rubbing tic out of the way now. You serious?
The cursing tics are really bad. This, that's 8, and it just comes out. I don't want it to happen.
When I'm eating, I hum as I eat things.
No, there's only 9, but I forget the 9th one. And I feel so bad that I have to do that out loud. Wait, this is my 10th tick, like doing this.
I roll my head around like this.
There's so many.
And I play with my fingers.
Last year, this new tick happened. It was like a fire alarm. It was so loud.
What was it?
Want me to do it? Okay. That was non-stop. Like every second in school.
They're getting worse and worse. I'm getting more. I just don't really like it.
So when did you first find out you had Tourette's?
Well, when I was in first grade, probably in December 21st.
I think I was about 8, maybe.
It started when I was 5. And now I'm 9. And it's hard.
I was about 7.
How old are you?
15.
8 years.
Yep.
That was my first tic. I remember the first day I ever had tics. I woke up, had to do that. A kid told the teacher on me.
On your first day?
On my first day, he told the teacher on me. He thought I was making a funny face at him. And that was just, I went home and my mind was blown. I had no idea what was going on.
The first tic I've ever had was a dust sound.
I had to go to a doctor and she explained what it was to me.
We were at the zoo, having a great time, seeing friends that we haven't seen in ages. Towards the end, for some reason I kept dying, like, duh, 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 duh. It was nonstop. And then we had to leave early, go to the hospital, see what was wrong. And the doctor said I had Tourette Syndrome, and I had no idea what that was.
How did you feel when she told you? I was mad. I didn't like it at all.
And then in second grade, I was doing this, which got me like put in my own separate reading corner. And so it was absolute like physical isolation and confusion and embarrassment.
They took you to the emergency room?
Yeah.
Were you scared?
I was kind of questionable. What is this? I've never done this before.
Did you feel like something was wrong with you?
Yeah. I don't know. I didn't know what, though. Duh, 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 duh.
For me, having a tic kind of feels like this kind of itch you need to scratch.
It's an urge, like a sneeze or an itch.
Like you need to do a certain movement or motion in order for that itch to kind of go away.
This is a tic that doesn't look good. And it feels like there's a mosquito bite. And these bumps are a product of like a year's worth of biting those individual spots. When people see it,
I can imagine they'd be like scared.
The first time I was asked about this,
It's like self-mutilation kind of.
a kid thought that I was like contagious or something. I really did feel like I had a disease and it sort of looks like I have a disease. There's something that I find a bit shameful about having my hands scarred like this.
What happens when you suppress one of your tics? I really hit the urge badly and I kind of have to do it again. Do you try and stop them when you're in school at all?
I don't know how to stop them.
When I'm walking, I have to do that
With your knees?
always. And it makes me nervous when I have to do bang my knees together because I always get bruises from doing that. I used to bang my head back like that, and it really hurt.
Do you ever try and hold back your tics?
Yes.
What happens when you try and hold
pretty
them back?
weird. You feel when there's an urge to do it. Wherever it is, it's in your stomach, then you do this. If it's in your head, you do that. And it's really annoying.
My best friend constantly, when he sees me doing this, he'll take my hands away and he'll stop. I'm like, it's not even worth it. If you hold it back now, I'm just going to do it more later.
Well, like how people need to breathe, I need to do this. So kind of like that.
I was in class and I suddenly really, really had to whistle. Really had to whistle. And I started by doing like this. I was like, no way I'm whistling right now. And it started to build up. And I really wanted to whistle. And all of a sudden, I couldn't listen to what the teacher was saying. I was just so concentrated about how do I satisfy this tic right now.
Since it was terrifying situation.
That's what I did. And a couple heads turned back. I think it's really embarrassing.
I have this tic and I have to curse with it. Sometimes I say the F word. I can never say it to anyone intentionally.
Yeah.
But it just comes out. doesn't feel good inside to do that. It bothers me because when I tick, then some people notice it.
Right. Well, I hope you agree that it's really powerful to watch real children with real Tourette's talk about it. And I think we learn so much just by watching and listening to them. But so let's now, with having seen and heard all that, let's now move into a slightly more academic presentation. And many of you will know that the history of tics is actually, and of Tourette's, is actually quite a long one. So the name officially came from Dr. Gilles de la Tourette. He was a student of Charcot at the Salpêtrière in Paris in the late 19th century. And Charcot had seen a patient with tics, and he gave Gilles de la Tourette, who was his registrar, his junior doctor, the job to go and make a case series. And Tourette described 9 cases with Tourette's or with this condition, and Charcot, the boss, said, cool, we're going to call this Tourette's. So that's where the name came from. So when you hear Gilles de la Tourette or GDT, that's the origin of it. But actually, even long before 1885, there were some cases. Itard, another physician, described a noble lady, the Marquise of Dampierre, who had body tics and barking and uncontrollable utterances, as they were described. And Dr. Samuel Johnson, the famous diarist, was said to have convulsive starts and odd gesticulations which tended to excite and surprise at once. And of course, there's the historical stories. Did Mozart have Tourette's? Did Claudius have Tourette's? The short answer is we never know. We will never know. It's interesting for people to speculate about that, but you know, it's an unfalsifiable hypothesis in a way. The classification, for those of you who were familiar with ICD-10 and DSM-4, the terminologies that were used in those systems were transient tic disorders, if you had it for less than a year, chronic motor vocal tics, if you had it for more than a year, and combined motor and vocal tics. And that's when we would call it Tourette's. And of course, there are always, as in classification systems, other and not otherwise specified tic disorders. The language in DSM-5 is a little bit different, but fundamentally, we're still looking for the same features. So we now talk about a provisional tic disorder. So this is when you have single or multiple tics for less than a year since their first onset, and they have to have started before the age of 80. So this is a childhood onset neuropsychiatric condition. And then you could have a chronic tic disorder if you have either motor or phonic or vocal tics for more than a year. So if you have lots of motor ones for more than a year or lots of phonic or vocal ones for more than a year, then we would say you have a chronic tic disorder or a persistent tic disorder. And we would call it Tourette syndrome or disorder, or GDT, Gilles de la Tourette, if you have one or more motor and one or more phonic or vocal tic for more than a year with an onset before the age of 18. So those are the main terminologies we would use. Here are the actual criteria for Tourette. First one, as you know, ABCD, A, multiple motor and at least one or more phonic or vocal tic. B, it needs to have a pattern. Well, they typically have a pattern of waxing and waning. They come and go, but it should have been there for at least a year, more than a year. C, onset before the age of 18. And D, it's not better attributable or described or explained by a substance use or another medical condition. And I'll say something about some other medical conditions in a little bit, particularly in our context. So, phenomenology. A tic by definition, and that's why I also wanted you to watch the little bit of the movie, because you could hear how these young people were talking about their tics. It's involuntary, so it's not something you make. It's typically rapid, so it's not slow movements. They recur. It's comes over and over again. And they're typically non-rhythmic, so they kind of burst of things rather than something that has a particular rhythm to it. And it's sudden and doesn't serve an apparent purpose. So if I, for instance, were to clear my throat because I have something in the back of my throat and I'm trying to get rid of it, that wouldn't be a tic. Or if I sniff because my nose is running and I don't have a tissue, that obviously wouldn't be a tic because it serves a purpose of some sort. And we can talk about simple tics and complex tics. And we talk about motor tics and phonic or vocal tics. So let me give you some example of those groups of tics. And you will have seen some of these already in the young people that we've just watched. So simple motor tics could include eye blinking, grimacing, pouting, kicking, bending, kind of leg bending. You heard the girl talk about that. Head jerking, tooth clicking, like that kind of thing. Complex motor tics can then be whole facial movements, biting. You saw the young man who bit himself, touching things, throwing, barking, spinning around, hopping, all sorts of complex motor movements. Echopraxia is when you imitate the movement of others. And often that's a hard one for people to spot. So if the teacher in the class does this and the young person with Tourette's does this, that could in fact be a tic because it's an echo phenomenon. But that will be quite tricky for people to spot, for instance. Copropraxia is the making of rude gestures. So if you, for instance, were to show the middle finger as a tic. Phonic, if we're not talk about phonic, and let me just say a word about phonic versus vocal. People can use the term either vocal or phonic. Phonic tic just means these are tics you can hear. So if you can hear a tic, it's phonic. If you can see a tic, it's a motor tic. And typical simple ones are throat clearing, or coughing, or sniffing, grunting, hissing. So hissing would be like or sucking kind of sounds. And complex ones can then be all sorts of combinations: syllables, saying words, saying phrases. Echolalia means echoing what other people are saying, either the sounds or the words or the phrases. Palilalia is the repetition of your own language. And usually the pattern there is people would repeat the end of the sentence that they are saying, a little bit like that. And you need to listen very carefully to spot those kinds of phenomena as well. And coprolalia is the saying of swear words or swear phrases. And you heard the girl, I stopped the movie just after she talked about it. This is the thing people typically associate with Tourette's. They say, oh, Tourette's, it's the swearing disease. And of course, it is a phenomenon that we see, but probably no more than about 10% of people with Tourette's would actually have coprolalia. And you could also see how beautifully this young girl described coprolalia. Coprolalia is not swearing. Coprolalia is the involuntary utterance of rude and inappropriate words and phrases. And so you could see people typically don't want to do it. They try to hide it. They're embarrassed by it. That's very different from swearing at somebody. So that's a really important thing. And it's an important thing for us not to joke about, because people with Tourette's really don't like it if we call it the swearing disease or those kind of things. Premonitory urges or sensations. You heard a little bit the young people talk about that. Most people, or many people with Tourette's, have a sensation that the tics are coming. Some people, Mary Robertson is one of the tic gurus, calls it sensory tics. So people have a sense that it's coming, and then they typically tic. And sometimes they try to suppress the tic. In fact, kids can go through a school day suppressing their tics as best as they can. But we'll talk about that in a second. So firstly, these sensations, very interestingly, they typically, people feel them in their shoulders or in the palm of their hands or sometimes in their upper legs. Very interestingly, we don't know why, it tends to be more on the right-hand side of the body than on the left. You have the sensation. People say it's like an itch you heard, or like a warm sensation, or like something crawling, and that kind of then is the thing that leads to, or that then is followed by the tic. the typical pattern of tic progression, if you look at tics over years, is they tend to start in the face. You all know, the blinking, often that's the first one. Teacher sees the child, they think he can't see, or sniffing, and people think a child might have allergy, or mum and dad thinks maybe this is an allergic child, but actually those are tics. And then they tend to go down the body, from the top, from the head and the face, to the neck and the shoulders, to the arms and the abdomen, down to the lower legs. That's the typical pattern, and that's what you will see over time in patients or in individuals with tics too. Just a comment about suppression. You all saw that these young people saying, I can suppress my tics up to a point, but A, they need to come out at some point, and B, it takes a huge amount of mental effort and concentration and focus to do that, which might make me unable to do the other things that I'm trying to do. For instance, concentrating in the class, focus on other things that I'm supposed to be doing. So there's a cost to tic suppression. But it's true that there are kids who go to school, their classmates may not see them having tics, and when they come home, they all have to come out, and there's very significant tics at home. And that's a pattern that's not uncommon for us to hear from families. If we look at the typical pattern, you've heard me talk about the waxing and waning of tics. And this is Jim Leckman, and this is a very nice review that he did some years ago in the Lancet, talks about tics come in bouts. So over the course of seconds or hours, they tend to group themselves. So Jim calls those a bout. And then over a matter of hours, there might be 1 or 2 hours where it's more prominent than others. And then over days, there might be days where it's worse than other days. And then over the course of weeks, there might be certain weeks where it's worse than other weeks. And in the course of a year, there would be periods where it actually clumps or clusters together. So he refers to it as bouts of tics and bouts of tics and bouts of tics. I can't even say it all. Bouts of tics. And that's really just to capture this waxing and waning, and they come. And so that when mum phones saying, oh, the tics are worse now, then we know that maybe what mum is describing is one of those bouts, and that this is part of the natural pattern of the tic presentation, rather than that we necessarily need to jump and do, make major changes to our treatment plan. Back to the typical age of onset and the severity, you heard these young people talk about when their tics started, and there is quite a predictable pattern to the onset of motor and phonic tics and associated phenomena. So this is what it typically looks like. Again, data from Jim Leckman. Motor tics tend to be the first to start. And here you can see usually from the age of 4, 5, 6, 7, so in the kind of preschool and early primary years is when we tend to see motor tics. And then the phonic ones tend to start a little bit later, maybe here age 6, 7, 8. And we'll talk about those soon. The obsessive compulsive phenomena that we often see associated with tics tend to start here around the age of 7, 8, 9. And so when a child comes with a possible history of Tourette's and they say, I was about 5 when I started having a motor tic, and I was about 7 when the first sound came, that's a classic description. If a child presents and mum says, I think he has Tourette's, and the child is 2, we're probably going to think of other kinds of pathology. In fact, that's when we're much more likely to think, might there be a different neurological condition? Might there be a seizure disorder? Might there be something else? And so knowing the typical pattern of presentation helps us to be more or less certain about the likely condition as well. And then if we look at the pattern of severity, I've mentioned bouts of bouts and it comes and goes. If we now look at the big picture over time, the pattern that we see, and this is from a very nice recent Nature Disease primer by Mary Robertson, who by the way is a South African psychiatrist who lives in London. And we call her Madame de la Tourette because she's probably the world leading expert on Tourette's at the moment. But she's an honorary professor in the Department of Psychiatry at UCT. So I've said they tend to start here around the age of 5, and the severity tends to go up and up and up and up. And the maximum typical pattern of severity is here you can see around the age of 10 to 12. the end of primary, start of secondary school is when we typically see the worst and the most prominent pattern. And then it tends to start to reduce and go down again. Now, of course, I've already said there are bouts and it comes and goes and it waxes and wanes. So the pattern doesn't look as smooth as the nice curves there. It looks like this. It goes up and down and 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 then so on and so forth. The very important thing that this graph shows us, and I always draw a picture, my pictures tend to be like up and down and up and down and up and down, is a key message to families, which is that most children with tics and Tourette's, by the time they are 18, have grown out of it. So at least 70% of tics and Tourette's goes away by the time people reach late adolescence and early adulthood. And that's an incredibly positive message to give mums and dads and young people with Tourette's, because if you are here and it feels unbearable, then it might not be easy for you to imagine that you could get to a different point. But that really is what it looks like, and I think that's a really important message to give to people. So, I've talked about the tics. Another very important thing to consider are the typical co-occurring conditions or comorbidities. Mary Robertson divides them into ones that suggest a shared underpinning and ones that don't. Doesn't matter quite so much, but these are the most common things that when we see tics, we have to look for and think about. 60 to 90% of young people have obsessions and compulsive behaviors. And I'll say a little bit more about that in a minute. So that's the majority. 40 to 60% meet criteria for OCD. About 60% meet criteria for ADHD. And interestingly, about a quarter have migraine. So there seems to be some cluster of migraine with these tic disorders as well, which is interesting. Autism I put at the bottom. A few years ago, people did say that there's perhaps an over representation of autism. Maybe it's true, but the evidence is not very clear. I still look for autism when I see tics and for tics when I see autism, but it's not as obvious and as very likely as those OCD and ADHD phenomena. And then other co-occurring conditions, very high rates of depression, very high rates of anxiety disorders, whether as a result of or independent of the tics and Tourette's itself, increased rates of substance use disorders. Some kids conduct personality disorders in adult life. I don't think these have been investigated quite as thoroughly as the neurodevelopmental associations. Many people with Tourette's have learning disorders, and often particularly with mathematics. And we very commonly see aggressive outbursts and some sleep disorders, and sometimes self-injury. Sometimes the self-injury is actually tic phenomena, as you've seen in the movie, but sometimes it's not. And then there's this very interesting phenomenon that Mary Robertson calls non-obscene socially inappropriate behaviors, or NOSI. That should probably be on the previous page. And that's when kids with Tourette's or young people with Tourette's may make typically it's socially inappropriate comments. The kind of things we might see in somebody who has autism saying, well, you look really bad in that dress, or, where did you buy that, from the charity shop, or do you know that you're really fat? And they understand afterwards that it was inappropriate, but it kind of pops out. And so that's another little phenomenon that we sometimes see. And that you can see is fairly common as well in association with Tourette's. OCD is perhaps the most complicated co-occurring condition. So I wanted to just say a few more words about OCD, obsessive compulsive disorder, in the context of Tourette's. You all are familiar with OCD, as we know, in the general population. So typically in young people that we see, it's associated with contamination, germs, hygiene, washing, cleanliness, showers, smells, and so on. And it tends to start a little bit later, and we have an equal distribution between boys and girls. When people have OCD in the context of Tourette's, the phenomena tend to be different. And the phenomena of the obsessions and compulsions tend to be much more about violent or sexual themes. You know, the kind of image or the urge to push somebody under a bus or push them underwater, or stick your fingers in knives or stab someone. Those are the kinds of obsessional phenomena that we sometimes hear about. Symmetry, that there should something be on the one side and on the other side. In fact, a lovely example from one of the kids in the clinic. I had a large clinic for children with young people with Tourette's, and the boy had a shoulder tic on the one side, and he was able to say to us, and then when I have the tic on the one side, I get the urge that I now need to do a tic on the other side to make it the same. So you can see how the tic does one piece and the OCD phenomenon makes him do something else. And so both of those required a treatment approach. Ordering, wanting things to be in particular places and sequences, touching things, doing and redoing, or doing and undoing, writing and overwriting. You can see these are slightly different kinds of phenomena to the typical ones that we see in OCD. It has an earlier onset. You've seen 6, 7, 8. Those phenomena tend to start more in boys than girls, and they tend to have a worse response to selective serotonin reuptake inhibitors than kids who have OCD without tics. And they tend to respond better to usually the combination of SSRIs, antipsychotics, and talking treatments. So you can see how that's helpful for us in clinical decision making. When we see someone with a combination, we know to expect a more complex treatment plan. I said I would say something about other medical conditions, and just 2 words about these, which you will read about and see about in the context of Tourette's. PANDAS or PANS are the 2 common terms. So PANDAS is pediatric autoimmune neuropsychiatric disorder associated with streptococcus, and I'll say a word about that. PANS stands for pediatric acute onset neuropsychiatric syndrome. PANDAS was described by Sue Swedo at the NIMH and colleagues in the early 1990s, and they said that they described this condition where after streptococcal infection, there's an acute onset of tics, OCD, usually those are the 2 clusters of phenomena, and it's associated with increased ASO titers and anti-basal ganglia antibodies. Now, the pattern is very distinct from the pattern that I've talked to you about before, that 4 or 5 or 6-year-old, and then more and more and more. So this is a child who was fine, had an acute strep infection, and within days have dramatic onset of tics and of obsessive compulsive phenomena. You can see, so the history will tell you the basic clue, but then the phenomena that you might see may look similar to those of tics and of OCD. And here, just, I'm not a Tourette's researcher. This is the closest paper that I've done in relation to tics and Tourette's. This is a work by Kathy Walker from Red Cross, who is one of the leading experts on Sydenham, Chorea. And you will all know that Sydenham, Chorea is a neurological condition that we see also in association with beta hemolytic streptococcal infection. And it's very common. So strep infections and cardiac problems are very common in Africa. And that's why it's useful for us to just bear that in mind. And so Kathy describes, and we here just outlined and summarized in this paper, if any of you are interested, that in Sydenham's Chorea, you can also get tics, aggression, emotional ability, ADHD, and these kinds of behavioral or neuropsychiatric phenomena, also with an acute onset, also as a consequence of a streptococcal infection. So this is a really interesting example where both PANDAS, and you can see there's some similarities and some differences between the 2. We won't go into that now. But these are therefore neuropsychiatric syndromes caused by post-infectious responses in our bodies that can be associated with tics and with obsessive compulsive phenomena. And so the treatment here is not the treatments of Tourette's. The treatments are typically immunoglobulin treatments and those sorts of medical interventions that can be very helpful. I said I would say one word about the neurobiology of Tourette's, and that is actually, maybe this is the summary slide. We actually know very little about the true etiology and the true pathophysiology of Tourette's. But if you want to go and read more about it in this Nature Disease Primer, Mary Robertson talks about it. And of course, it's kind of hand-waving, because what we are saying at the moment, and if families ask us, we would say it is something to do with the pathways in the brain that regulate movement and the control and the output of movements. And in the brain, in the different pathways that regulate input and output of movements, there are different neurotransmitters, and some of them are excitatory, so they stimulate things. Some are inhibitory, so they inhibit things. And so we think that tics and Tourette's happen when there's a dysregulation, an imbalance between the excitation and inhibition, the stimulatory and inhibitory kinds of signals or pathways in the brain. You can see that's a very, very not specific explanation. If people want a biological explanation, that's fine. And this is the best, I think, answer that we can really give people at the moment. Back to some clinical practice, because ultimately this is what we need to do. And ultimately, the key message for us as practitioners and for families is there are lots of things we can do to help people who live with tics and Tourette's. And so to do our assessment, first we're going to do a thorough developmental history, a family history, because tics do run in families. We're going to look for those simple motor tics, complex motor tics, simple phonetics, complex phonetics. We're going to look for what makes your tics worse and what make your tics better. And this is the key intervention strategy as well. We're going to look for the comorbidities, particularly the ones we know that are common: obsessive compulsive behaviors, obsessive compulsive disorder, ADHD, and possibly ASD. We're going to think about and look at their cognitive and school performance and do a neurological examination. And just one word before I go on about the OCD and the OCB phenomena. You've seen that I showed you how these phenomena may be different in Tourette's. Violent themes, sexual themes, symmetry themes, ordering themes, etc. Unless we ask children about these sorts of things, they are highly unlikely to volunteer it to us. Almost no 7 or 9 or 12 or 15-year-old will tell you that they have these images or impulses to push their sister down the stairs. I had a child in the clinic who, when he was in the swimming pool, had the urge to push children under the water. I had a kid who had the urge to push his mother under a bus. Children will not volunteer that information to us unless we say to them and ask them specifically. Sometimes when kids have tics, they also have these thoughts and images and impulses. And sometimes they don't want to think them. They get very disturbed by it. Have you ever had some of them? And gives perhaps some examples. And that's when we're more likely to get these illustrations and the information from them. Principles of treatment. Once you've made your diagnosis, we're going to do the following things. One key intervention for everyone is psychoeducation and support. And this is something we can all do wherever we are in the world, regardless of the amount of equipment or resources we have available to us, to tell people and to talk to people about tics and Tourette's, what it's like, what it's not like, what commonly comes with it, what the pattern is over time, and that for most people, they will grow out of it by the time that they are adults. This part of that, we're going to say, let's make a list of what makes your tics better and what makes your tics worse. Usually, and I will qualify that, usually the kinds of things that makes tics worse is A, when people draw attention to tics, when people are asked to stop ticking. What are the two most common things that we see in schools? Stop that, why are you doing that, why are you doing that? When people have to do things quietly, so quiet reading, or sometimes when they're put on the spot. Also, what often makes tics worse is when people get distressed or even when they get very excited. So again, it's about arousal. I had the very sad case of a child in the clinic who, whenever he got excited, his tics got worse. So much so that at Christmas time, he tried not to get excited about getting gifts for Christmas because he knew that that would make him tic worse. Isn't that terrible? But you can see by just understanding that, already we can think of an intervention. Because the other side of that coin is typical things that make tics better is focusing on something, doing something active, usually when it includes motor action like walking, drawing, running, jumping, cycling, that kind of thing, singing, whatever that might be. During sleep, tics tend to be better. And interestingly, when people have a fever, now I'm not going to say get a fever to get better, but often that's the pattern that we see. And so when we can think with a young person about what makes your tics better and worse, and therefore, what can you do when they are worse to try and shape them to be less impairing? Just a note there, the pattern of what makes it better and worse is very different for different people. So don't assume there's a recipe. Engage with this young patient about what their pattern is like, and then help them use their pattern of what makes it better and worse. When Tourette's is mild, which is the case for many people, the above might be enough. We may not need to do any other intervention. When it's severe, we might start to add medications, and I'll come back to medications. And if somebody with Tourette's has one of those comorbidities or co-occurring conditions that we talked about, we will treat the comorbid condition first. If the child has tics and OCD, we will focus on the OCD in the first instance, because tics are driven by anxiety and by arousal dysregulation. So if he has an anxiety disorder and we treat that, the tics may in themselves get better. The OCD is treated, the tics may get better. The ADHD is treated, the tics in themselves might get better. So that's the principle of treatment when we see tics and co-occurring conditions. School liaison. This is, apart from working with a young person to understand their tics and family to understand the tics and what it means, school is a fundamental environment that we have to engage with. You will hear, and if we have time to listen to more of the movie, or otherwise you can also go and listen, many children with tics are bullied. Many young people with Tourette's have profound impairment as a result of people not understanding their tics and Tourette's. So a key step for all of us is to go to the school, to think with the child and the family. Okay, how do we talk to the head teacher and to the teacher? And how might you want to tell your classmates about your tics and your Tourette's? And what do you want them to do when you tic? Very often in school, we help children come up with a plan where if they feel they really need to have a little tick break, they might give the teacher a card or a sign and they go out of the class and they go and tick for 5 minutes and then they come back. Because now they're more able to focus again. For instance. So it's just about coming up with knowledge and an action plan with everyone in the school environment as well, or at college or university or in work, wherever it may be. So first, the non-pharmacological treatments, other than over and above psychoeducation and the kind of basic self-help management that I've mentioned, is now the evidence-based intervention is called CBIT, Comprehensive Behavioural Intervention for Tics. And it's a CBT-based approach, and I'll show one slide about that. People use exposure and response prevention when people have tics, and particularly when they have obsessional or obsessive compulsive phenomena as well. One might use deep brain stimulation. I don't know if anyone in South Africa uses deep brain stimulation, but in some high-income countries, DBS is used particularly for severe Tourette's, when it's really hard to treat or when it's often resistant to pharmacological treatments. And in profoundly impairing situations, people might use neurosurgery to try and get to some of those motor regulation pathways in the basal ganglia that I've shown. These are not treatments that any of us will do. We might do the top two. We certainly don't have a likelihood of using the bottom two anytime in our practice. Just then one slide about CBIT, because CBIT is a useful fundamental approach, and the CBIT therapists call it, it's a do something else therapy, not a stop it therapy. Because as I've already said, if I say to somebody with tics, stop that, we're likely to increase the arousal and the anxiety, and they're likely to do it more. And so the basic steps of CBIT is firstly, psychoeducation about Tourette's, tics, what it is, what it isn't, as we've talked about so far. Some self-awareness training. So let's become aware of your tics, your premonitory urges, your sensations, where, when, what. Relaxation training, so that the young person can then work on relaxation in the moment at the time. And then the fourth step, and this is what is known as these second two ones up, it's a habit reversal. You would establish a tic hierarchy. So what are the most important ones? What are the least important ones? What's the one I want to focus on? How do I make it? What makes this tic? And then you work on formulating a competing response. So if the tic is a head jerk in one direction, maybe if you feel it coming, a stretching kind of action on that side might be the thing to reverse or control it to an extent. And then, of course, the last bit, which applies to all of us, but also as part of CBIT, is social support for the young person, for their family, for school context, etc., so that when they try to do these things, that there's an understanding and a support for that. There is an online, in this day and age of COVID, there's an online thing called a tic helper. That's a CBIT tool. The problem is it costs money. And so if people have money, you might want to Google it and have a look at it. But we're always trying to think, what are things that we can do without huge resources to support families? Something about pharmacological treatments is useful. We would typically not, as I've already said, we would typically not use medications when tics are mild, when they don't bother people. Often they look worse to us than they feel or are experienced by the person who has them. So we need to know whether people would want to have a treatment for their tics as well. Many people choose not to. If we're going to use pharmacological treatments, typically it would be when tics are very severe, when tics are painful. You've seen the girl talk about the kind of head jerking tic, so when it's painful, when it might risk harm to the body. So for instance, there are kids who have like eye poking tics. So if you have an eye poking tic, or if your tics prevent you from eating or drinking or swallowing, then those are the kinds of components of the tics that we definitely would want to think, how do we, in addition to non-pharmacological treatments, add a pharmacological approach? And in most countries, European certainly, UK certainly, clonidine is the first line of treatment, of pharmacological treatment for young people with Tourette's. And you might all have heard of clonidine. In fact, it's an antihypertensive drug. And when we use it in tiny, tiny doses, about 25 to 50% of people with Tourette's respond to clonidine. Maybe motor tics respond more than phonic tics, it's not clear. It tends to have fewer side effects than these atypical antipsychotics that I'll show you in a minute. But we start, you can see 12.5 to 25 microgram to 50 microgram twice a day. So I tend to start once a day, twice a day, and then increase twice a day. And you can do it 3 or 4 times a day as well, with a typical dose of about 150 to 250 microgram per day in divided doses. It can take a while to see the effects, and clonidine, no medications in Tourette's will make the tics go away. There's nothing that will do that. But it might reduce the severity, and it might reduce the frequency in some way. So it might flatten and stretch out that curve that we see of tics. Common side effects of clonidine are sedation. Sometimes mums say, well, actually, it's useful if he's a little bit sedated, but it's very sedating in the first few days, irritability, sleep problems, etc. These are the common side effects. And of course, the key thing for us is you might get rebound on rapid withdrawal. So you might rebound tics, but you may also have a rebound hypertensive response. So hypotension, remember, it's an antihypertensive drug. So you might get a sudden shooting up of blood pressure. So we warn people, don't just stop it suddenly. But it's a very cheap medication. It's available in South Africa. So this is a useful first line of treatment. Clonidine is also very helpful when kids have Tourette's and ADHD, because it's also a second/third-line treatment for ADHD. And it's very helpful when kids have kind of aggressive behavior. So if you see a kid with Tourette's and ADHD and aggression, this may be a really useful medication to consider for treatment. You know the other possible treatments, haloperidol, old-fashioned antipsychotic drug, used to be the first-line treatment for children, and it's still used in some parts of the world. The dilemma is, the good is we get reasonable response and improvement, but many people have side effects, and you can get really nasty other motor disorders, dystonic reactions and extrapyramidal side effects and so on. That is not ideal. But it can be used as a treatment. Risperidone is now used in many countries as one of the first-line treatments at low doses, not high doses. And again, the side effects are clear: weight gain, sedation, extrapyramidal ones. Mary Robertson, and in the UK, particularly for adolescents and adults, use sulpiride, which is not very commonly used in South Africa, but it is an antipsychotic available for people to use. And aripiprazole, of course, is another one that's available. I want to wrap up and just zoom back out to what we're trying to do when we treat people with Tourette's. Yes, we need to think about the tics and the associated clinical features and the co-occurring conditions and the coexisting other psychopathologies. But ultimately, it's about seeing a young person and the functional impact that these conditions have on them. So we want to think, what is the psychological impact of this thing, and what can we do about that? What's the school impact? Big one. And what can we do about that? What are the social impacts, the intellectual or cognitive impacts? What are the impact of these obsessions that they might have? What other physical impacts may there be? Because ultimately what we want to do with our intervention plan is to bring all of those components together, so that what we do is not just the treatment for the tics or for the OCD or for the ADHD, but really a comprehensive treatment that considers all their life domains, so that our ultimate task is to see how we can bring together a support plan that will improve the quality of life for people who live with Tourette's. There are lots of other support, and I always encourage people to look at Tourette's Action, which is the UK charity and non-profit organization. They have lots of lovely resources and activities and lists and things, etc. One of the cool things that Tourette's Action did was they made little cards, like business cards for kids with Tourette's, that they would say to them, carry it around with you, and when in the supermarket somebody stares at you, give them a card. When in school somebody calls you names, give them a card. And on the card, there's basic information about Tourette's. And I quite like that. And for some kids, that's a really empowering activity to do. That's just one example. The second thing I recommend to families who have some money and are able to buy a book, in fact, the book is now available online as an ebook as well, is a guide for parents and professionals by Uttam Chowdhury and Tara Murphy. Uttam is a British child psychiatrist. And it's a lovely little book that talks in simple principles about tics, about Tourette's. And for many people, this really is a sufficient approach to treatment, because it just gives them all that psychoeducation and information that people might need and want. I recommend it to everybody. I have an older version of this on my shelf in the office. For those of you interested in further reading, the Jakobab e-textbook has a chapter on Tourette's by Veit Rüssner, who's a German expert in Tourette's. He's in Dresden. In fact, we had a young patient from South Africa who at some point went to the clinic there. Mary Robertson's Nature Disease Primer is interesting. Any papers by Mary Robertson I would recommend. The European Tourette's Guidelines. You can go and read more about CBIT and about psychoeducation for tics and Tourette. So lots of things that might be interesting for all of you. In the interest of time, I'm not going to go back to the movie now, because I can see that it's time for us to stop. So I think what I might do is to stop sharing and end there. And if there's time for us to discuss some questions or clinical matters or any points that any of you want to raise, I'm going to suggest we do that next. If you want to ask a question, feel free to unmute yourself or type it in the chat box. Any of those would be absolutely fine.